Good afternoon, everyone, and welcome to today's Lunchtime Learning presentation. My name's Mary Ann Joyce, and I'm the physician liaison here at OHC. And today's topic is CAR T therapy in multiple myeloma and amyloidosis, presented by Dr. A.G. Galal, who is a medical oncologist and hematologist here at OHC. He's also the director of stem cell transplant and cellular therapy. This presentation will be recorded, and I will send out the recording to all of you after the presentation. Dr. Galal sees patients at our OHC Kenwood location. Take it away, Dr. Galal.
Thank you very much for the introduction, and good afternoon, everyone. Thanks for including me in this very important topic. Over the next 15 minutes, I'd like to just show you what we have currently as a standard of care and what's coming through the pipelines, which is really a lot. There's currently over 31 trials in multiple myeloma and CAR T only. So it is a very important point, and CAR T has changed our practice dramatically. Started in lymphoma, then acute leukemia, acute lymphoblastic leukemia, and now multiple myeloma has really changed in terms of management for that. So I'm going to sort of go over these kind of changes with you. Next slide, please.
That's nice, though.
It's still 7.
So what's available right now? The first product that you would hear about is Carvykti. Carvykti is basically dual BCMA targeting. BCMA is present on the plasma cells, the malignant plasma cells, and it's targeting actually the VHH nano antibodies or nanobodies, which is a very new technology in targeting the CAR T. The co-stimulatory pathway is a 4-1BB, which is a very slow kind of starter, then becomes a plateau later on, which might account for less side effects, as we see with CAR T in lymphomas when we use the CD28 co-stimulatory pathway. Initially, it was approved as a fifth line or fourth line treatment. However, that was expanded to second line treatment for patients that refractory to proteasome inhibitors and IMiDs, specifically lenalidomide refractory disease. Sorry, that slide is just not showing the rest of it. Here we go. Basically, the first CARTITUDE trial did show median progression-free survival that not reached versus 11.8 months. Overall response rate was 98%. Stringent CRs were 82% in a very heavily pretreated patients. Next slide, please. The second product that we've been able to use is the Abecma made by BMS. This is a product that we use less than basically Carvykti at OHC, and it's sort of a different target, but also the BCMA position, and we're using the same co-stimulatory pathway. Initially was approved for fourth line of therapy, and now it is actually the second line of therapy. There's an echo there that I'm not sure why. The KARMA trial did show median progression-free survival of 13.3 versus 4.4 months. However, there is no significant overall survival difference at 30 months of follow-up. Going back to Carvykti, we actually have overall survival advantage when we looked at the trial. So this is the reason why we probably would use Carvykti more than Abecma at OHC. Next, please. So the key question would be, can we move CAR T earlier in the lines of therapy? So for instance, can we do it as a first line of therapy? Can we do it, with patients that have never been treated before? The question actually could be answered in many ways, but based on the CARTITUDE-4 that I just showed you the results for, we've seen patients that had 1, 2, or 3 lines of therapy, and we've seen benefit across all the population there. And very interestingly, is the high-risk cytogenetics like p53 mutations, chromosome 1 gain, and definitely the extramedullary disease, which is very difficult to treat, did show actually quite effectiveness of the CAR-T in this trial. Next, please. So for frontline CAR-T studies, there are few that actually at ASH this year, there were quite a bit of results for follow-up. So if you look at the CARE multiple myeloma 001, it's 100% MRD negative at 3 months. This is really big. When you have 100% not only response, but depth of response at MRD, this is great. The CR rate was 94.4%. Median follow-up was 15.8 months. There were no progression observed at the time of showing these kind of results. Also, another BCMA CD19 dual targeting. I know that CD19 is not extensively expressed on the plasma cells, but the malignant plasma cells actually have CD19 positivity. And as you can see here from this trial, the 100% stringent CRs and MRD, again, very impressive. But what's even impressive, one of the hurdles that we have currently for CAR-T is the manufacturing time and the necessity to treat in a shorter period of time. This trial showed the fast CAR-T platform, which is 30 hours of manufacturing and expansion in vivo for these patients. So again, very important progress there. You look at the number of patients that were 70 years or older were quite well represented on this trial. Therefore, this trial works for older patients as well, which, as you know, in multiple myeloma, it's a mainly older patients' disease. The CAR PRISM, it's a high risk for smoldering myeloma. I'm sure you're aware that we are treating these days high-risk smoldering myeloma with daratumumab, and sometimes we add Revlimid to that to try to delay the progression. So the CAR-T was tried in the same fashion, and specifically Carvykti was tried there with 100% MRD negativity. What I'd like to see is the long-term follow-up and basically seeing significant progression-free survival compared to what we're doing with daratumumab or with a sort of standard of care. Next. So novel CAR-T. So our problem is BCMA can be exhausted in terms of usage, especially if you use bispecifics as well prior to the CAR-T. There are mutations that can happen in the BCMA would prevent the sort of targeting of that kind of sort of target. So now another target that came up is the GPRC5D target on the plasma cells. It's very effective actually post the BCMA exposure and failure. So another way to salvage these patients through CAR-T. Next, please. So different trials targeting basically the target, different target. Looking at the first trial here, overall response rate of 71%. 7 out of 10 patients were post-BCMA therapy, so really a very good response. Now the 3-year overall survival is 59%. This is not frontline therapy. This is basically for patients been treated previously, and most of these patients treated with multiple lines of therapy. The Arlo-cel is another one that's doing the same fashion and targeting the same target, basically overall response rate of 96%. And it's given as 2 doses. There's a phase 3 trial is being planned currently and being accruing patients. The anti-GPRC5D as a salvage post BCMA CAR-T is another way of looking at double whammy. Basically, you're giving 2 types of CAR-T, 2 different targets, and the phase 2 overall response rate is 84% with 35% CR rate in 37 patients. You're going to see this in a smaller number of patients because it's very early trials, but these results have been discussed at ASH and EHA, so very well established kind of results, and it's a nucleus for progression of these kind of trials to more in the sort of FDA approval kind of arena. having a fully human anti-GPRC5D is very important, because that way you probably don't have the immunogenicity that you see with the other types of constructs. And with this, overall response rate showed at 94%, CR rate and stringent CR rate is at 72%. The median progression-free survival is 18 months. A meta-analysis of all these trials has been pooled, and you see the overall response rate is 89%. There is a lower relapse rate if you compare it to the BCMA CAR-T. So this is really very exciting. And my expectation that we're going to have so many choices for CAR-T for multiple myeloma in the coming years that it will benefit all our patients. Next, please. So what about the dual targeting? I mentioned one of them doing the CD19, but also you can do dual targeting by a specific CAR, not necessarily two CAR-T back-to-back, but more of the same construct, having BCMA and GPRC5D on the same construct. Phase 1 relapse refractory multiple myeloma with extramedullary disease had 100% overall response rate, 44% CR rates. Looking at the BCMA and CD19, as I mentioned before, it's 100% stringent CR with MRD negativity in newly diagnosed multiple myeloma. Now, to come around the manufacturing time, it's actually very good to think of the off-the-shelf allogeneic CARs. And with the allogeneic CARs, it's basically giving a living drug in your clinic whenever you decide that you want to give it. This is a CRISPR-edited anti-BCMA. This is the Caribou trial, which we have here at OHC for our patients. So if you have a patient that you think eligible for CAR-T, that would be one of the options that we have currently. Anti-CD38 constructs, multiple phase 1 trials is recruiting currently. Novel targets, as you can see here listed, there are more than one that we can talk about it, but for the sake of time, I'm just going to mention that there are multiple targets like the SLAMF7, elotuzumab kind of target, which looks really promising as well. The BAFF receptor, the multiple myeloma 920 trial is happening over there for phase 1. So in early development, these kind of targets are happening as well. So we're going to see more and more trials and results for multiple myeloma. Next, please. This is a very important kind of information about the anito-cel. The anito-cel is a product made by Arcellx. It's a small biotech company that was bought recently by Gilead. And the reason why they bought it, the results were very, very good. And what you can see here is the phase 1 and phase 3 trials. We had the phase 3 trial at OHC, but now it's closed, completed, and the data are being analyzed. This is a synthetic D-domain binding domain. So it's a non-single chain variable fragment. So makes the sensitization and the allo or the immunogenicity is much less when it's a synthetic domain. So we have really advantage there that way. It's using the same costimulatory pathway motif plus CD3 zeta activation domain. As I mentioned, it's engineered to reduce the immunogenicity and improve stability. So with this kind of costimulatory pathway and having the no immunogenicity against the construct, you can predict that these patients can have the CAR-T circulating for a much longer time than the other products. And actually, there are deeper responses happens overnight when you use, over time, when you use the anito-cel. That's very encouraging to see more and more in-depth kind of responses. Currently, phase 3 trial is completed, as I mentioned. It is not yet approved by FDA, but actually there's a promise to approve it by Q3 of this year. So it is very interesting CAR-T that's coming out, and I think it's going to be probably the major one that we're using in the field. Next, please. So just to show you a couple of results on anito-cel in the phase 1 trial, overall response rate is 100% and stringent complete remissions of 75%. Very good partial remission, 88%, and MRD negative, 85%. So the depth of the response is very, very good. Durable responses beyond 18 months, and that's what we want to see with our patients and our CAR T, especially in the front line. Now, it's going to be the bigger question is, do we still need stem cell transplant for multiple myeloma patients as we do currently? And there is a trial, the Nordic trial is currently addressing this question in particular, looking at patients receiving frontline CAR T, I think it's Carvykti, versus going through the standard and having transplant as a consolidation after the first line of therapy as we do currently. I think this trial will be a milestone trial if it proves that transplant is not needed anymore, which my feeling that's going to be the case. It's educated feeling. So let's see the results of that. Next, please. The safety profile is very important because honestly, the cytokine release syndrome, when it's severe, grade 3 or 4, it's alarming and it's causing much problems for the patients. And sometimes patients actually decline CAR T because the worry about the side effects. Cytokine release syndrome is part of that. But when you look at most of the cytokine release syndrome with anito-cel, it's usually grade 1 to 2, very low grade, very short kind of occurrence. Grade 3 or higher were 4% only of the patients. The ICANS is another very important side effect, and we can see on the anito-cel, it's 4 out of 25 patients had ICANS. Most of them, if not the vast majority, is basically less than grade 2, so grade 1 or 2. Grade 3 were 2 patients, all resolved by 30 days post-CAR T. What I would like to emphasize with Carvykti, we have delayed neurological side effects as Parkinsonism-like syndrome. We have autoimmune kind of colitis that can happen from that. And actually, this is not seen with this construct whatsoever so far, even after finishing the phase 3 trial. Next, please. Here's just a very simple table to show you the difference between anito-cel that's coming soon to our clinic versus the Carvykti and Abecma, which is available currently. So from the binding domain, you have the synthetic D domain with the anito-cel, which gives it advantage for less immunogenicity. The co-stimulatory pathway is the same, and I think it's the right one to use for its slow increase or slow action, then plateau, which makes the side effects are much less. And CRs are again, back again, please. Oh, thank you. So when you look at the side effects, again, the grade 3 or 4 CRS are very, very low occurrence across the board. And the movement disorder did not happen with anito-cel nor Abecma. It's only with Carvykti that we see these kind of movement disorders like Parkinson's kind of syndrome. And also the autoimmune colitis has not been sort of observed. As you know, right now, Carvykti is approved for second line, Abecma as well, and anito-cel is not approved as of yet, but I'm expecting this by the fall that we're going to see the approval from FDA. Next, please. So the potential advantage, as I mentioned 5 minutes ago, absence of Parkinson's-like neurotoxicity, synthetic, non-immunogenic kind of binding domain, and the impressive efficacy, especially in the extramedullary disease, which is, as you know, is a very difficult situation in terms of response to other systemic therapy. Next, please. So this is the phase 3 trial, randomized trial, which was here at OHC, and was a randomization between anito-cel and the standard of care. And This is a list of the standard of care if you're interested, but just wanted to show you that this trial basically is being analyzed right now. It's going to be the culprit for the FDA approval. Next. So we'll move now to the AL amyloidosis, a very difficult disease. Fortunately, it's rare, but when it happens, our treatments sometimes are not very effective, and if they are, it's a short-lived kind of effectiveness. When you look at the natural history of amyloidosis, eventually every patient will progress and die from their disease. Stem cell transplant and the novel therapy did help a lot, but actually you cannot deny the potential effect from the CAR T in this disease. And because it's sort of coming from the same plasma cells or clonal plasma cells, the BCMA is very well expressed on these abnormal plasma cells. It's a potential for deep hematologic response and actually organ responses. So when we look at the very small amount of studies currently and very small number of patients, but very effective. Next, please. So when we look at the different trials, the largest one, accrual, is 16 patients currently had relapsed refractory AL amyloidosis. 14 out of 16 patients had triple class refractoriness. 13 out of 16 had cardiac involvement, which is something that actually we try to sort of not do stem cell transplant for, because the outcome would be very poor. You look at the hematologic overall response rate is 94%. Looking at the CR rate is 75%. Organ responses, and this is really big. You look at 8 out of 13 patients that had basically organ response. So it's reversing the organ damage. So if patients have kidney disease, which there are trials for kidney disease in particular for amyloidosis, that reverses, and patients might have a normal kidney function. The CRS mostly was low grade, which you would expect because the burden of disease in amyloidosis is not really as huge as what you see in multiple myeloma or in lymphoma in general. Grade 3 CRS were 3 patients out of the 16, and no grade 3 or 5 CRS. The median overall survival was 10.1 months, but this is a very short follow-up, so we'll wait to see further follow-up for these patients. Next, please. Another trials, but much smaller patient population there for relapsed refractory amyloidosis. All patients had kidney involvement. I don't think many of the patients on this trial, so only 6 patients had cardiac involvement. They had 100% hematologic response rate and 100% renal response. This is just amazing to look at these kind of trials. Opens the door for patients not necessarily having renal transplant eventually, and with mild CRS and no ICANS. This is like a magic kind of construct, but only 6 patients. So I have to really be saying this with a grain of salt, because we have to keep in mind that we have to put more patients on the trials and to longer follow-up. Next, please. So my last slide here, and I'm hopefully on time. It's at 12:23. So the bigger questions that we're going to have: how to use CAR T optimally in terms of sequencing with treatment. And many of the trials that I just mentioned will give us the answer to this question, including the trials in the frontline therapy or comparison to the autologous stem cell transplant as a standard of care. The engine escape phenomena, and this is BCMA loss at relapse. That would make it very interesting to look at the GPR C5D, which is showing effectiveness in BCMA failures. Also, the other targets that I mentioned might open the door for much more effective construct in this kind of situation. Manufacturing, it's still a problem because the vein-to-vein time remains a barrier. Sometimes we need to treat our patients as soon as possible, but the next generation platforms like the fast TCAR, 30 hours of manufacturing, or the in vivo expansion, and also over-the-shelf allogeneic products might come around this kind of issue. Toxicity management, and have you seen the slide before and the one before, basically looking at the CRS and ICANS are much lower in terms of the occurrence compared to other diseases and other constructs actually in CAR-T and myeloma. So this might be much better in the future to treat these kind of patients for CRS and ICANS, or even not have them to start with. Clinical trial landscape, as I mentioned at the beginning, there's 31 plus active trial for multiple myeloma, and there are so many products in the pipeline that's going to make it to the market in different lines of therapy. The novel targets, the allogeneic constructs, the combination strategies for the dual engines, sometimes actually thinking of triple engines. That will open the door for much better outcome using CAR-T in multiple myeloma. I think I'm on time right now, and I thank you very much for your attention.
Thank you, Dr. Galal. That was really interesting. Does anybody have any questions? You can come off mute if you'd like, or put something in the chat. Oh, doesn't look like we have any questions at this point. So
Very
thank
good.
you all. Thank you, Dr. Galal, and thank you all for attending. And I will send out the presentation shortly.
Great. Have a great day. Thank you.
Have a great day. Thank you.